All right. Well, I just want to say welcome everybody to our third session of the Public Housing and Partnership Resource Toolkit Learning Collaborative. My name is Matt Beyerschmidt. I am the Senior Program Manager for the National Nurse-Led Care Consortium. So we are, sorry, my screen is being blocked. A few housekeeping notes. To adjust or remove captions, click the live transcript button at the bottom of your Zoom window and select hide subtitles or show subtitles. Feel free to ask questions. Please add your questions to the speaker and comments for the speaker and comments for the group into the chat box. If you're having any technical issues, please raise your hand and let one of us know, and we'll reach out to you directly through message. And just so you know, this session is being recorded and will be available afterwards for you to review and to support. So the National Nurse-Led Health, our partners on this program are the National Center for Health and Public Housing, and their mission is to strengthen the capacity of federally funded public housing primary care health centers and other center grantees by providing training and a range of technical assistance. Also, we are the National Nurse-Led Care Consortium. We're a membership organization that supports nurse-led care and nurses at the front lines. NCHPH provides expertise to support comprehensive community-based primary care, policy research and advocacy, technical assistance support, and direct nurse-led healthcare services. A review of the learning objectives. 1, perform a review of 2 case studies from Healthy Together Toolkit. 2, engage in discussion regarding the practice and implementation, is that the right word? Implications of reviewed cases. And 3, review foundation, collaborations, and technical details of working with specific foundations. I'm going to pass it on to Kevin really quick, but I might need to pass my shared screen off to somebody because I just saw my dog walking down the street and I have to go get him. He somehow got out.
Pass it over, man.
So,
I got you.
I'm going to pass it to Marcella. Marcella, can you share the screen possibly?
Yeah, just send me the link to the presentation and I got you.
I'm coming. Someone's got the dog on. Yeah, you can open the gate. 1 second.
Yeah, I heard about the dog, so I needed to run too, I guess. Good luck.
Thank you.
Wait 1 second, everyone. I'm opening the presentation. My screen.
Yeah, thank you. I'm so sorry for everybody. I'm watching this dog and he got out. I don't know how, so I just had to go get him. I saw him walking down the street while I was giving my intro. Marcella, do you have it now?
Yeah, I have it. Kevin, you'll let me know when to.
Thank you. That's Kevin's first slide.
When to change slides.
Yeah, so this is stuff we've all seen at this point. Just to briefly go over, folks are often surprised when we talk about just the presence that FQHCs have in our nation's healthcare. One of the benefits of the pandemic is I think folks had a lot more appreciation for the system because it was so often in the news and so obviously at the front lines of the pandemic. But I'm shocked often that people are so surprised at how big the numbers are, how many people that our facilities see and how many Americans we serve. So there's about 30 million patients altogether. When we look at the populations that our organization specifically seeks to support, the FQHCs that are in or immediately accessible to public housing, we go to about 5.7 million patients. That's also a very large group of folks, about equal to the 1.5 times the DC metropolitan area. And our 108 public housing PHPCs that specifically serve public housing have about a million patients. So this is a very large population. And an important thing that I like to mention during our webinars is I don't think there's a single health center in the country that's not seeing any people that are HUD-assisted or in public housing. So this is an important population throughout the country, not just for organizations that are directly granted to take care of them. And trust and believe, if you haven't seen HUD-assisted adults or adults who live in public housing in your center, it's because you haven't asked. They are there. So there's my advocacy for on their behalf to make them as visible as possible. We will move on to the session now. Next, please. Next. And of course, our demographics. I think the important things when looking at demographics are what's the important thing here and what does this tell about the population, its history and its needs. The thing that things that pop out to me as a physician and an epidemiologist are one, the numbers of the population that are from historically oppressed, disenfranchised, or otherwise economically excluded groups are disproportionate members of this population. So issues that relate to those groups very often relate to public housing as well. They are also disproportionately, perhaps the most disproportionate of the statistics on this field are the number of female-headed households. So the focus on programs that support and empower single mothers and female-headed households are also of particular interest in this population. A program's sweet spot is for places that could focus on all those populations. Things to keep in mind. Next slide, please. A reminder that this is from all the material covered in this session is taken at least in a cursory basis from this toolkit. It's not a replication, but a complementary learning collective. For those of you who are interested and have not read through it yet, my recommendation would be look through Module 1 and Module 3 to get the most high yield experience. Module 1, of course, looking through the programs and types of collaborations. And Module 3 that we'll be focusing on today looks at some case studies, specific programs that represent different types of collaborations and different degrees of effort and different degrees of organizational relationship or entanglement, let's say, that all bring with them unique needs and unique requirements as far as documentation and unique needs as far as communication as well. So the link is, I'm going to pop it into the chat in a moment. So we will be on Module 3 throughout this session. I recommend looking through that. If you go through Module 3, I will be, if there is time, briefly touching on some potential foundational partners. In the context of really running a health center at all and being interested in interorganizational partnerships, but also particularly in the context of the current needs that the end of the public health emergency has presented to our various professionals at various levels of HPHCs. Now's a good time to be thinking about it in this manner, external funding, and if it's something that, given the effort that's required to get it, if it's a smart place to put effort at the time. My suggestion is that to bring it on the table by looking at the options. So we'll go over, there's a variety in the toolkit, including the NECC Foundation, which has a strong presence in community development and health. The average award is about 87,000. It's a competitive process, but for those of you who have good programs that have been also accompanied with good documentation, you may find yourself in a position of strength in those sorts of applications. And if it's something that you haven't considered and you have both the manpower and the bandwidth to do it, I would strongly suggest putting it on the table, at least for a conversation with colleagues at board meetings or so forth. Put it on the docket. Next, please. The format here will be similar to last time. I'm going to be, we have Jason from HUD with us again, and we'll have additional guests coming in later on the session from health centers to provide a health center perspective. But what I'll be doing is going over some of the case studies and presenting questions for us to pull apart based on the case studies. Now, I've chosen a variety for specific reasons. And the first is Housing the First 100, a Florida-based program that I picked because of its inter-organizational complexity. Now, up to this point, for most of the webinar series, we've been talking about a let's say, simplified relationship of one or two different organizations working for a set goal. And I think the housing and Valley Health organization that our guests mentioned, program, the WIC and later dental services program that our guests mentioned on the first class is a perfect example of this. It's a single effort by a handful of organizations, and it came and arose from a very organic reason within the community. What we find often down the road is that I've seen interorganizational partnerships that are 35, 40 years old. And it's interesting when talking to folks that have been stewarding these for a while, the life cycle of an interorganizational partnership is very complex. And the complexities that are interesting and high yield for this audience is that longstanding partnerships grow, they build, and they bring in new partners. For those of you that are involved in a partnership from the beginning, it gives a position of strength if a organization partnership is if a program is successful. For those of you who have had like successful programs that have either gotten press interest, grant interest, and so forth, the program almost becomes a little corporation to itself in that it has its own PR, it has its own communications, and so forth. These intergroup large collaborations are also things that have often have a road in for organizations that were not in from the beginning. And my request for all of you to put on your consideration topic, if you are in a position at your organization when you're saying, well, we have a variety of problems here in our community that we would like to solve, a variety of organizational restraints that we would like to navigate. Partnerships are, of course, if we discussed, an important way of bridging those. But novel partnerships aren't the only option available to you. And for those of you who are in especially larger cities where there's just a lot going on, you'd be surprised how many things or consortiums, centers of excellence, or so forth, who are particularly hungry for people with an understanding of what's going on the ground and for opportunities for to efficiently serve folks in need. So please keep your eye out and your focus on that, and we'll be kind of going into this a little bit. So as I mentioned, I chose these collaborations because they involve multiple stakeholders and advanced development timelines with different organizations joining and leaving throughout the lifespan of the program. Some multi-center programs also evolve into centers of excellence or service consortiums as they become more complex. And from an organizational growth perspective, the things that often catalyze that are things like external grants or large awards. And where do large awards come from? They come from a history of documentation of excellence or of a strong existing partnership. So I want to be clear to contextualize these things within sort of a lifespan of where a program can evolve to and what options are available for those who are stewarding programs through various parts of their lifespan. So housing the first 100, it's funded through various sources, including local hospital. Florida Hospital Center is the largest health network in the Orlando area. I think it's been renamed Advent Health in the last year, but Florida Hospital is still a well-known name for it. Local government and HUD consortium of a HUD grant for a homeless shelter consortium called Central Florida Foundation. So essentially, can we go for the next slide, please? I started without you guys. So essentially, what this consortium did is we have local government. We have Florida Hospital System, a very large medical system, the Homeless Service Network, which is funded by HUD, local law enforcement, and local government coming together for a similar problem is that they are all expending large amounts of resources in inefficient ways to support those without homes. And the consortium and the focus was an opportunity to bring various strengths of various organizations together in order to solve it. And what I like about this and how they did it is, one, the roles and responsibilities of the various organizations were very were very well drawn out and very complementary. And two, they had a very good agreed upon process. So the crux of the program, I'll get into in a second, but this is kind of a diagram that goes through the lifespan of if a person without a home were to be identified at a Florida hospital location or at a homeless shelter, what would happen? They would fill out a standardized form. They go through a coordinated entry into the program process. And then there's an agreed upon prioritization process whereby certain individuals are put on a list in certain orders based on their needs. And the individuals are found housing locations and given systemic support in in the form of job training and so forth. So from the perspective of someone who, from a grantor, this is a program that's brought multiple stakeholders in. It involves community in all aspects of its implementation. Also, they have a very clear and scientific design for their program. The strength of that is communicated in their some of their diagrams. For those of you who have programs that might be complicated and might be difficult sometimes for grantors to understand their impact, having good things like this that show how a patient will experience something or show how an organizational flow will happen, it gives a level of clarity to folks that are considering funding or considering expanding funding that I think is helpful at the very least, and at the best may put you at a distinct advantage. Next, one moment. I think I have some more. Oh, so to discuss the care coordination here, I think I did that. Okay, next one, please. And sort of a focus on their coordination. The issue being that these organizations were all dealing with spending large amounts of resources on folks without homes, and this was a strategy for them to have better outcomes with less money. So next slide, please. Questions? And Jason, do I have you for in the room?
Yeah, I'm here. Can you hear me?
Okay.
Hey, Kevin.
So to discuss multi-organizational collaborations.
Kevin, I think you had a question. What was that? Someone spoke up.
I'm sorry?
This is Rod. I had a question.
Do you
mind going? Can you go back 2 slides? Yeah, right there. What does the city visibility list mean under the prioritization?
Yeah, so they have the city visibility list, I believe, is coming from local law enforcement based on either folks that are known to law enforcement or not known to law enforcement. They appear to have a very complex process with how they prioritize folks. It's clear there was a lot of stakeholder involvement in that. And this was the law enforcement's contribution to that. The details regarding how exactly they're choosing are not disclosed in their documents, and we'd likely need to look at something internal to see that.
Thank you.
And move down the slides when you get a moment, but just to go right into the monologue here. In my own experience, the issue that I have the most, and I'm going to project it on you here because I feel like it's a pertinent point, is managing communication. Managing multi-center collaborations, particularly in the beginning, can be difficult, especially under times of institutional strain. So the question that I have to pose to the group here are sort of what are some of the main difficulties when managing communication in multi-institution collaborations? Jason, do you have a thought about this before I give my own 2 cents?
Yeah, can you hear me?
I can. Oh.
Great. So, I mean, I think maybe this is not even unique to housing, but pretty much all of our partnerships, by definition, are multi-sectorial. And I think of it as, the social determinants of health and housing being a real core of that, but it's not, all of it or the full picture. And so, when we're thinking about, well, what do folks who have housing, need, it can be an array of different issues, right? It could be healthcare, but what we often find is that there are other issues as well. So, perhaps someone presents with asthma, but what's really going on is there's air quality issues in the home, or there's mold or pests. And so, the partnership is not just saying, hey, we need to refer you out and here's some place to go, but then, how can we take whatever information that they're gathering, even in a de-individualized way, or in some cases, individual, if there's permission, to then take a next step with that, right, and do some sort of remediation.
Mhm.
It could be in the case of, let's say mental health, there can be a whole series of things that affect someone's life. And we know that the two greatest needs are transportation and childcare in our communities. And we hear that again and again.
Mhm.
Those are really, so, as a healthcare provider, if you're hearing from somebody that they're having, all of this stress or strain around, child rearing, one of the things I would think about is, well, is there a childcare provider in that community? So I think of all of these as being sort of as part of SDOH being interwoven. And then as part of that, right, not just having a conversation around, well, what can we get from you, but what do we all bring to the table, and how do we ensure that there's collaboration so that this information, gets spread around?
Jason, as you're saying that, something came to mind. You said that most of your work is with multi-center collaborations in one way or another. As you've seen these, have you noticed any trends or interesting points that might be pertinent regarding communication? As in, have you seen anything that is a persistent issue that organizations have in their own communication with themselves, or in defining or organizing their communication with the grantor, in this case, HUD?
Yeah, I think that's a good question, right? So, I mean, part of it is, I think we talked about it before, people often feel because of, let's say HIPAA or other sort of legal requirements that, well, we can't really discuss anything. And, that may be true on an individual level, but so, for example, if you're a provider and you're noticing that there's a high incidence of asthma in the community, right, that is something that you could have a conversation with the housing provider around. So I think one sort of just fundamental piece is sort of understanding and creating mechanisms where you can share critical information. You don't feel that you're divulging someone's PII, but also that you're able to have deeper conversations about community needs. I think that's really fundamental. One of the changes I've seen during the pandemic is, particularly around COVID, I think there was sort of at least some thought that started to be given into, okay, with contact tracing, or just hey, if somebody's positive, we don't necessarily have to tell that person's personal information, but we could let the community know, hey, there's, this is the rate of positive tests in the community, right? And this is some information that you should be aware of. So I think just an understanding of public health data and the value that could have to cross-sectoral partnerships, I think that was a real sort of lesson learned from the pandemic. And then I would say, in terms of actually communicating with like the housing provider, I think just having an understanding that that is sort of a natural base of operation. So, sort of not saying you should always go to them, right? I mean, there should be some reciprocity, but, that's where the people are. And often that's like, so when, doing things like food distribution, it's always going to be more successful if it's on site. Right? When you're having a meeting around community transportation needs, it's always going to be more successful on site than having folks go down to the, bus headquarters office and have them meet there. So I think those kind of things too, especially now that we're doing a lot of virtual meetings during the pandemic, I think that really increased access and made it a lot easier to have those kind of connections.
You make a really interesting point there, Jason, is that housing departments make great partners because they happen to administrate the things that people live in, and have and realistically, if you're trying to get things to people where they live, is a great base to focus your program on. And they kind of just naturally make good partners. Is that kind of a point that you were trying to make there?
Yeah, and I think, people often think about housing partners as like, oh, well, these are people that provide housing, right? But they do more than that. That's a platform that you can then use to reach people about so many other needs. So absolutely.
So it's almost like when I think of sort of the services that housing organizations have, it's sort of like you can kind of think of it as an infrastructure. And communicating with patients requires infrastructure. Most of us, the exam room is part of it, but communications at home are a big part of it too. And they come to the table as collaborators with that infrastructure. So I think that's a very good point. You did mention something about data sharing and like HIPAA compliance and so forth. Is data sharing in that context an issue that you think health centers are struggling with in their collaborations?
I think sometimes actually it's the housing providers that are struggling with this. So that's where they can really lean on the health centers to better understand it, because there's a sort of initial fear of anything that has legal liability, right? And then that can create a roadblock where, a lot of times it's easy to get a no. And so, how do you then get to yes? And I think one way that you do it is when you have good examples of, hey, here's some folks from the health center, here's maybe even their lawyers. You don't have to take their word for it, but this is a common understanding of what public health information is and why that's different than individual data that's protected by HIPAA. And here's ways in which we can use this and can't use this, and here's best practices around how this should be communicated, because that's ultimately, even if it is legal, if it's not communicated in a way that people feel comfortable with, it's just as big of a problem. So I think just working through that together as partners can help prevent that from becoming a roadblock that then sort of stops meaningful collaboration.
The more you talk about it, the natural sort of partnership between health centers and housing authorities makes more and more sense. But the way that it makes sense to me, and it did in the beginning, is sort of these are organizations that desire very similar outcomes. They want their populations to be fed, happy, healthy, and that's very similar to the things that the health centers want for their patients as well. And they will also both bring very distinct strengths to the table. So I think that's an important point to get across when we're discussing that I just wanted to emphasize once again. But some things that are important that sometimes seem go unstated is the importance of having, just from my perspective, having very good and professional communication with your collaborations, keeping your meetings, keeping your quarterly meetings, and making sure email communication when it's done is done like fluidly and it is done on time. That can maintain rapport in a way that really supports a relationship, particularly in the beginning stages. Interestingly, when I've seen early collaborations or engaged in early collaborations and they've fizzled out, oftentimes it's been an early communication barrier that's led to that, either a misunderstanding or just a bad rapport in communication that has had led to that. Next slide, please.
We'll reshare it. There we go.
And I think we will go straight to case study 3. So there are far too many of these for me to go over them during the session, but something I just wanted to make clear for those of you who do run programs, when I was looking through and doing a review of these programs as sort of like the perspective of a consultant and looking at their web pages, for those of you who run successful programs, communicating to the outside world how successful they are is a very important part of your brand recognition and the recognition of your program. And the details of the Harlem Children's Zone, you can see in the slides. I'm going to sort of breeze over it. But one thing I did really like about them is they have very effective visual communication. They have their numbers on their website of how much they're serving. They have good infographics that show what they do in a very clear way. For those of us who manage programs, we understand our programs very well. They make perfect sense to us. To the public and to grantors, that's not always the case. Programs are very complex and it can be difficult sometimes to develop a mental model to understand them. Having good visual communication about your program and its impact is a very important part of maintaining it. Next, please. So case study 4, CHW Path. This is a consortium between 2 health centers, Access Point and Watts Healthcare. Essentially, it's a program to embed community health workers into public housing. So it's a place-based approach to health. Essentially, the program was piloted in 2019, and its goal was to create local CHW job opportunities for residents of public housing, and to essentially use the CHWs to perform work for both of the health centers. So the pilot program was very successful, and they managed to hire quite a few people from the local communities. And the thing that I found very attractive about this is I think we're all thinking a lot more about investing in our communities in a job training, from a job training perspective, particularly for those of us who work in public housing, that your community is really an important reservoir of human capital. It's the recipient of your programs, but it is also a reciprocal relationship that can come back when you train and you use folks in your communities. Jason, I was wondering if you had a perspective on health centers hiring within their communities and how that can help a collaboration.
Yeah, well, obviously this program is near and dear to my heart, as one of the collaborations that I helped to co-lead. And I think, I say that though, understanding that really the work happened on the ground. So, we just provided some of the supports and funding and training opportunities. But I think the key thing from the CHW Path collaboration was having buy-in from both the health center and the housing department. So, I think the particular details aren't so important, whether it's a 50-50 funding or there's some other funding source, but just the idea that both sides are bought in. And what that could look like might be different at different sites. It could be having, part-time at the health center, part-time at the housing authority. It could be, having a supervisor actually at the housing authority when they're there working on outreach. It could be something where if there's a clinic co-located on site, maybe that's just their home, so to speak. I think one really interesting thing about this collaboration is at 5 different sites, it took different forms in each of those 5 sites. So, they may be talking in one place about vaccine confidence, in another place around digital connectivity, in another place around maternal and child health. And so I think just what's so great about these types of programs is they can be responsive to local needs. And those needs are actually oftentimes better understood by having CHWs on the ground, because they're the eyes and ears. So I think it's a great form of collaboration that when you think about the cost is not very high, but does require, of course, some real buy-in from both sides in terms of leadership.
So a follow-up question for you, Jason. If I'm understanding the breakdown appropriately, the consortium, the community health workers that were a product of the collaboration, that the local sites had say on what exactly they were trained in and what they were doing. Is that correct?
Yeah, I mean, they really, sort of developed the entire needs assessment locally. They, put together their MOUs locally and, ran the programs. So, the main thing that we really helped to provide was just some guidance and, templates, best practices, and some funding and training and TA dollars. But ultimately, those are nice to haves, but I don't think they're actually essential. I think the goal with these types of programs is to find sustainable funding mechanisms that aren't necessarily tied to grant funding. But to give the example of, Watts Healthcare, they actually, this was right on time for them, right? They had a grant where they needed to do outreach into the community. And so this made sense for them, and it made sense for the housing authority. We had this opportunity, but then, those grant streams have both gone away, and they've still maintained and expanded the collaboration because they've seen the value in it. So, sometimes I guess the greatest benefit to something like a pilot is it just creates that initial connection. And then when folks see the value, they can take it from there.
So if I'm remembering what you said correctly, there was an initial grant one of the parties brought to the table. At a certain point, the grant either expired or wasn't renewed, and they continued the collaboration by investing their own resources. Is that correct?
Mm-hmm. Yep. And, there were other mechanisms too, right? There was some Medi-Cal reform that I think maybe allowed that to continue, and, some uniqueness to maybe California, but, that sort of outcome is not unique to California. We saw that happen as well in Baltimore and other places.
Mm. And as you're saying that, one of the issues with grant funding is the uncertainty around renewal, especially when you invest quite a lot of time into a collaboration, a center of excellence, something of the sort. But I think the important thing that this case gets across is that the parties eventually needed to shift their funding, and they were able to do that because of the infrastructure that the original funding helped to facilitate. The collaborations are very much like, I don't know, roads and cities, in that your infrastructure that you create and your relationships and so forth, your building protocols and implementation, that infrastructure is very valuable. And even if it's a temporary grant funding that allows you to develop that, this gives you fodder to take the relationship to the next level on your own, or to diversify your funding and build upon it. I appreciate your insight on that, Jason. Thank you.
Of course.
Do you have any other thoughts about Watts Healthcare before we progress?
Yeah, I mean, I'll just say, there's 2 of the partners on here. We had, many more across the 5 sites, and each one had their own individual motivations. So, it really is not one size fits all, but I think it's just understanding sort of, where the overlap is for each. And, there were a lot of other ancillary partners that were even beyond the health partners that made this successful. We did convenings in Baltimore and Los Angeles, and we brought together 30, 40 different community partners into those meetings and said, hey, this is what we're trying to do here. Is there a place where you can fit in? And it could have been as small as, oh yeah, we could maybe do a food distribution with the community health workers, or in the case of Los Angeles, it was, yeah, we could have them work on digital equity and increasing access to connectivity in the community, because we know that's going to increase access to healthcare and telehealth. So I think even if the collaboration is with these 2 partners, it can be a catalyst to bring in other cross-sector partnerships to the table and find ways that you can support those.
In this and a couple of other of the questions I've asked you over the weeks, Jason, you talked a lot about sort of motivations, how things have come together in various programs. And it seems like, let's say, a collation of motivations at times. That this one has a grant, this one has an interest, this one has extra staff, and they all happen to get into a conversation, and the program kind of is birthed out of that communication. When I have managed multi-organization collaborations, the lifespan of the collaboration poses different difficulties. And the things towards the later in the lifespan, the documentation, evaluation, and so forth, were things that I've always felt more comfortable with because there was a process to them. What I always struggled with was finding ways to find good partners in the beginning and being able to understand those motivations and to understand the perspective of other potential partners. I was wondering if you had any thoughts or perspectives on that, on just, is there a system to find good partners? Is there a perspective, or do these things kind of just fall together naturally?
Yeah, I do think in some cases it's just leveraging pre-existing partnerships, but in another sense, it's like any good brainstorming exercise. You cast a wide net and then you kind of see what sticks, what seems to have the most momentum. And it may not necessarily be what you're thinking of as the best fit. It could just be, well, you have the most motivated collaborator over there, and maybe that's more likely to make it happen. Or it may just be where the funding is and makes sense. So but I think unless you have a really good grasp of like you're already in regular contact with partners, bringing together a convening around this can be a really good way to get a sense of what's possible, and then to kind of figure out what's going to work from there. And we have seen this work not just in health collaborations, but in digital equity. We've had our Connect Home sites, do these sort of convenings. And even though they're maybe a one-off, I think they can spark longer lasting, ongoing collaboration. And they can be good reasons to get local leaders. We've seen this happen with many of our convenings where they'll get, a local dignitary or elected official. And, that can also be a way of getting buy-in, but also, showing that this is a serious endeavor. Getting residents there, right? That's another, I think, huge part of it, and just getting the word out that, hey, this is happening and this is what we're thinking about, and what do you think? And, gauging what folks in the community feel. So I think even though I know there's a lot less of this happening after COVID, I think doing a convening in an intentional way, whether it's, around program design or just getting to know one another, or a resource fair, there are lots of different ways to do it. But I think it can be a great way to kind of get a sense of who's out there and who's interested.
As my thinking on this is, I think similar to yours, Jason. I really appreciate your perspective on this. But when I think of it, of sort of the social relationships that you're describing, I kind of think as collaborations and partnerships as an outcome, and the sum of the social relationships with outside organizations, with other professionals in your area, via conference and so forth, if you think of those as being all of the social relationships that, say, a member of a board of directors or an executive or a staff member may have, and you take those across the organization and you take it across all the decision makers, those are the collaborations and partnerships are really a function of those social relationships. And I'm very rarely hearing about programs from health centers or housing departments that aren't in some way anchored to an existing social or professional relationship. People rarely just jump into bed and do programs together. It requires a great deal of trust and understanding. And I think as we are getting back into slowly back into more in-person and more consistent virtual communications with colleagues and other organizations, that those social relationships are going to be increasingly important for institutional resilience. Do you have any thoughts on that? Anyone? Thoughts, questions, or concerns before we transition?
I think you said it pretty well.
So if I could go to the next one, the next slide, please. I wanted to briefly go over some of the HHS guidance on the end of the public health emergency, and to transition to some questions about the public health emergency ending and its implication on partnerships that we did not address. But I just wanted to briefly go through these two slides as far as what won't be impacted and what will be impacted. Per the HHS fact sheet, the impact at a glance, these are the things that will be affected by the end of the public health emergency. Matt or Marcela, do we send these slides out at the end of the session automatically?
Yeah, we send a follow-up email like a couple of days after.
Okay.
Yeah, so they'll help.
Okay, excellent.
The recording of the slides.
And next slide, please. And impact at a glance, the things that will be affected. Some pertinent things here being coverage for COVID-19 testing for Americans, certain Medicare and Medicaid waivers, certain FDA COVID-19 regulated guidance documents, and so forth. For those of you who missed our webinar, the webinar the other day that Jason hosted, that went through some of the details, these are on the slides, as well as just links to other. If you have any questions or concerns about the end of the public health emergency, certainly reach out to us. Is that something you are available for or able to answer questions about if necessary, Jason?
Yeah, for sure. And we really appreciate that this is an ongoing sort of area of new information as agencies kind of figure out what this means. So, we may put out another webinar once we learn more about, the
Excellent. Thank you for that, Jason. If anyone wants to get in contact with our speakers, I think they're to send us an email first, or what's the system on that, Matt?
We can include it in the follow-up email. I'll put the speaker contact. Oh,
Excellent.
am I still muted? Oh, no, okay. Yeah, we'll include the speaker contact information and a recording of the presentation and the slides.
Excellent. If we could go to additional topics, please. It's the next slide. Excellent. So on this, with the end of the public health emergency on May 11th, we thought it would be best to touch again on partnerships and specifically how they could be impacted by the end of the pandemic. The end of the public health emergency. In speaking to health centers, the main areas that I'm hearing where people are struggling are in workforce, that many folks are having to cut down workforce, particularly those that are engaged in non-reimbursable actions or workflow. Workflow also being an issue with the loss of staff and impacting services, and particularly social services being cut. So before I go on, does anyone have any specific issues about the end of the public health emergency that they'd like to pose questions of, or are they'd like to raise their voice about? Well, I guess I have a question for you, Jason. Through your efforts in dealing with this, what are some of the main issues that you folks are dealing with from the inside in stewarding us through this? Yeah,
so I mean,
and to be clear, just the HUD perspective of what are your challenges in the public health emergency, and if you don't mind.
Yeah, well, I think the good news is a lot of HUD programs are not winding down at the end of the public health emergency that were created in response to the pandemic. So there's, the emergency supportive housing vouchers that are continuing and have several years of funding left. And I think that's been a great tool and resource that folks have been able to use to help folks who don't have stable housing, get a foothold on that. And those are still available. I think also, some of the flexibilities had already phased out that were part of the original CARES Act, but we've taken to heart some of the lessons from those. So I know, the program that I helped to run, FSS, we've continued to offer sort of a waiver in terms of the participation count requirement for that program. And we haven't, up until this point, limited funding to anyone based on that. We may start doing that again in the future, but, we've given people, I think, pretty broad leeway there. And, I know there's like a mortgage program that's kind of winding down. But, I think at that point, it's more about getting people into home ownership and less about, stable housing or just affordable housing. So I think the good news is there are not a lot of programs from a HUD perspective that are ending. I think one of the challenges that we've learned is that every time there's a change, there's a potential for confusion, a potential for sort of lack of understanding or lack of trust. And I think what's happening now is a lot of this stuff is happening, and it's, when there's good news, it's always communicated vigorously. And when there's bad news, it can be, less fun, or there's less of a desire to share it out, but it can be even more important. So, folks having to, recertify to stay on Medicaid, that's a big one. And that's something that folks may be really dealing with that could be affecting a lot of patient populations. It's a concern that we have, that people may not be aware of this requirement and may miss their window to do so. So, that's a big one. And we know it varies by state, but that makes it all the more complicated to communicate out on a national level. So we really lean on folks on the ground, having those interactions, maybe just doing some blanket communication to the community around this. It's really important. Similarly with the end of the enhanced SNAP benefits, that's another one that folks, really took advantage of. We've already experienced this with the end of the enhanced child tax credit payments. So there's just been a lot of, I think, great things that came out of it in terms of supports, but as those go away, and if there isn't really good communication about how or why, I would just, think about, well, not only the negative effect on people who are affected, but, next time, what is that going to lead to? And it may lead to a lack of trust or participation in these programs, which wouldn't be great for the family and isn't the ideal outcome. So we're hoping that by communicating, we can at least have people be prepared for what's happening and feel like they understand it. But it is really complicated. And like I said, we only really skimmed the surface on yesterday's webinar, but we do hope that folks on the ground are, taking to heart some of the lessons of the pandemic around, just the importance of communication. And I think we all learned that about just, getting the word out about the vaccines and about COVID and making sure people really understood the key messages there in a very simple, easy to understand way.
This is from my own conversations with colleagues and constituents. This is sort of a extremely unique moment at the end of a sort of extremely unique period. And something that I'm commonly hearing is both challenges and how quickly it's coming up, in particular focus on the folks getting kicked off the Medicaid rolls and the unpredictability and who is and who is not, depending on what your state policies are. But also uncertainty in how organizations are going to be able to continue to provide services. A lot of organizations have made the determination that they will be cutting services or will have to cut workforce in, thank you, Rod. Good seeing you. Have a good day. They'll be cutting workforce, or they will be cutting services, or so forth. These are essentially triage decisions that the organizations are being forced to make, and I think it's a very difficult situation. And when you don't have resources to plug in to fix the missing resources issue, it can be difficult to be helpful. What I'm hearing from colleagues and how they are thinking about it, and those are folks in the CEO chair or the CEO chair, COO chair, is that regardless of the end of the funding when it was available did provide a lot of infrastructure. It provided a lot of telehealth infrastructure. It provided a lot of staff that's for the time being still present. And it provided a lot of ancillary staff and a lot of training. And importantly, I think the pandemic has given all of us an ability to deal with crises that we never really thought we'd be able to develop. It's difficult to make statements that apply to the diversity of the FUHCs that are in our country. But I think it's important to remember that we all are in fairly strong positions to deal with this. If a funding shortfall was in a different context, it may be a different matter entirely. But for those of you who do have infrastructure or do have things available that the pandemic has produced, now is a great time to be able to be pushed to think creatively about it. And creatively using community health workers, creatively using your technological infrastructure, and creatively using the lessons that you have learned through a very difficult time will be, I think, exceptionally important in being able to make your institution go through this transition in as powerful a position as they can. So I guess I'll end by saying I have a lot of faith in our organizations to be able to get the information they need and be able to use what they have to traverse this difficult and uncertain time. What I'd like to say is both of our organizations are available as needed to provide consulting or support services, even helping you talk through a difficult accounting and or research or evaluation issue. What I'd ask is, Jason, if you have any final thoughts on your own or HUD's perspective on the end of the public health emergency, or if any of our audience has something they'd like to share.
Yeah, I'll certainly defer if there's any thoughts or questions in the audience. I'll just say, I think we've all, as you said, gained a lot of resilience from this, but I think, there's also a lot of fatigue and burnout. And so, one thing I would just encourage everyone to think about is, as we move away from COVID, it doesn't have to mean a shift away from the priority of health. And so, housing agencies may not be looking at their backlog of unmet resident needs that need to be addressed, and they may not be thinking, okay, well, now we have to get to the next big health issue, right? So this could actually be a really critical time for sitting down together and saying, okay, what are some of the things that are coming up that we can work on that aren't COVID? And maybe that's, catch-up immunizations, which could include COVID, right? And maybe that's back to school, or there could be an array of health issues around summertime. So I think, just keeping that engagement going and not letting it fall to the wayside because, sort of we're out of the public health emergency phase of the pandemic. I know personally the new guidance around bivalent boosters, I think is intended to be simplifying, but is actually in some ways complex to understand. And so, just knowing that that information is not really readily understood or available, and being available to communicate that, I think, is also really critical. But I know we're looking at, and I mentioned this before, an array of health needs beyond the pandemic. So we'll be doing a webinar next month on mental health and trauma-informed care. And I just think there's a lot that we haven't really touched on during the pandemic because we've been so focused on COVID. So now is really an opportunity to look at other health or social determinants of health needs in the community and think about addressing those, as part of this larger shift. But we really do appreciate all of you, being part of this conversation, and happy to continue it if folks want to reach out one-on-one, certainly.
Thank you, Jason. Thank you, everyone, for your participation, and thank you for your continued service to your and our communities. So thank you again. To our colleagues at NNCC, do you have any final words?
No, we can just share the last, maybe reshare this. I'll reshare it actually. I'm dog free. Hold on a second, I'll do it. But we want to thank our speakers, Jason and Kevin, for joining us today. And we also have a post-eval link. We will send it out, but it should pop off automatically after you sign off the Zoom. So we will also send a link out to the post-evaluation along with the slides and recording and whatnot afterwards as well. And here's all of our contact information. I will share this out as well, along with the rest of with Jason's info as well, if you want to reach out to him. And that's it. Thank you. We were a little over time, but thank you, Kevin. And thank you, Jason, again for contributing. And thank you, everybody, for joining us. And we'll see you next week.
Have a fabulous week, everyone.
Bye.
Thank you.
Goodbye. Thank you.
Bye.
Bye-bye.